Good morning. This is the audio lecture for chapters 4 and 5. Chapter 4 goes over or talks about the patient record, and it talks about it as it applies to the hospital, physician office, and alternate healthcare settings. Chapter 4 basically deals with defining the patient record and talking about the purpose of having a patient record. It summarizes the development of the patient record, and it also talks about alternative storage methods for archiving records. So we first start off with giving the definition or description of what is an actual patient record. So basically a patient record is classified as a business record. It is we refer to it sometimes as a encounter of all of the different type of healthcare services that a patient has. I get the question all the time, when is a patient record actually established? A patient's record is actually established the moment he or she notifies the doctor's office and comes in for an appointment. At that point, a record is established. And I say that because a lot of times some demographic information is already given on the phone after the patient has made the appointment prior to them actually coming into the facility. So it is at that point a patient record is basically established. So in a patient record, one of the first bits of information and the most important part of the patient record is the demographic information. This is all of the information that is tied to the patient. It includes things such as the patient's name, date of birth, place where they were born. A lot of times you have to give like mother's maiden name or father's maiden name, Social Security, employment, insurance information, and so forth. When we look at the patient record, the patient and electronic patient, the paper and electronic patient record both has several purposes, but they only have one goal. I'm going to say that again. Paper and or electronic patient records, they have many purposes, but one goal. And that one goal is documentation of patient care. In other words, what I'm saying is no matter if it's a paper record or if it's an electronic record, regardless, documentation of all patient care is what the goal is. And what I mean by that is every single thing that is done to a patient, for a patient, that applies to a patient, all has to have documentation inside of that patient's record. And I tell students all the time, my favorite saying when it comes to patient documentation, if it wasn't documented, it wasn't done. Even if you say, oh, well, I know I gave that patient that shot. Oh, well, I know that I called the patient back. Oh, I know that I said for this to take place or for that to take place. If it's not documented in a patient record, it's as though it was never said and or done. So, what is medical transcription as it applies to patient record? Now, if you remember from chapter 2, when we was talking about different careers, medical transcriptionist was one of those careers that we talk about. Now, there's a difference as far as medical transcription and medical transcriptionist. So transcription is basically the process of taking patient information that is stored on computer media such as a hard drive or a disk or a tape. It's the process of taking that information and typing up a dictated report. And the person that does that, the person that listens to the dictated information and keys this information into a report, that is the transcriptionist. So you have medical transcription, which is the process of dictated information. And then you have the transcriptionist, who's the person that actually performs this process. Now let's talk about definition and purpose of the patient record. Definition and purpose of the patient record. All right, so number one, let's talk about who owns the patient record. Who owns the patient record? And then we're going to talk about how does patients have rights to their record. So now when we look at who owns the medical record, the facility in which the record is housed, like whoever has the actual record in possession, whoever has it on their property, it belongs to that facility, okay? But the information in the record, that information belongs to the patient, okay? So I'm going to say that one more time. The medical record is the property of the provider and is governed by federal and state laws. However, the information inside of the record belongs to the patient. The patient owns that. So the patient has rights. How does the patient have rights to the record? The patient has the right to access the contents for review. Patient has the right to do that. And they also have the right to request that any inaccurate information is to be amended. Okay, so patients have rights to review their records, check for any amendments that need to be changed, and they have a right to ask the provider to amend that particular information. But the medical record itself belongs to the facility in which it is housed, but the information is owned by the patient. So, what is a hospital inpatient record? Basically, the hospital inpatient record is the record that is used to document all care and treatment that a patient receives while they're in the hospital. Doesn't matter what it is. From the moment they're admitted to the hospital up until the moment that they're discharged from the hospital, any and everything that was done to that patient, that was given to that patient, that was assessed through that patient, all of that is housed in what we call a hospital inpatient record. A hospital outpatient record is that record that documents any information, care, and treatment given to a patient that was done outside of the hospital. So let's say the patient went through the emergency room, or the patient had outpatient surgery done. Or let's say, for instance, the patient was kept for observation overnight. Any of those type of services that were given to the patient, those things are documented in what we call an hospital outpatient record. The physician office record is pretty much self-explanatory. Any care or treatment given to a patient that has been received or given in an actual physician's office. Okay, next we're going to talk about how we authenticate patient records. How do we authenticate patient records? So first, let's talk about authentication. Authentication means an entry is signed by the provider, or an entry is signed by the nurse, or an entry is signed by another healthcare professionals. Okay, so there are pretty much 3 ways in which authentication of patient records can occur. The first way is signatures. The first way is signatures. Counter signatures, initials, and then some other ways would be fax signatures, electronic signatures, or computer key signatures, and then signature stamps. So let's kind of go through and talk about each one. So let's talk about first signatures of authenticated patient records. When signatures are provided to authenticate a patient record, it must have these items: the provider's first initial, last name, and whatever their title or credential may be. Counter signatures are those signatures in which an additional person, like additional provider, can sign off on a record that's already been signed off on. That's called counter signatures. Now, countersigning signatures or countersigning individuals must be qualified to be able to do that type of authentication. Okay, another way to authenticate patient records is through an initial. Now, initials are usually used when flow sheets need to be authenticated and medication records. So anytime a flow sheet or a medication record needs to be authenticated, that's usually done by way of initials. Then you have fax signatures. Fax signatures are only allowed based on federal and state regulations. Rubber stamp signatures. When using rubber stamp signatures, provider must sign a paper or document stating that they're only going to use that stamp for the sole purpose of authenticating documents. That's the only way that a rubber stamp can be used to authenticate a patient record. Now, the question on the slide says, which insurance company does not allow the use of signature stamps? And the answer to that question is Medicare. Medicare does not allow the use of signature stamps or date stamps on certificates of medical necessity. But that's for durable medical equipment. So Medicare does not allow the use of signature stamps or date stamps on certain certificates of medical necessity for durable medical equipment. And then lastly, we have abbreviations and how they're used in the patient record. Every facility should have a documented list of abbreviations that are allowed in their facility. Okay, not every facility will allow certain abbreviations, and basically abbreviations are to be used at minimum and only when given in that list that's provided by the facility. Meaning that if your facility does not allow certain abbreviations to be used in a patient's medical record, you cannot use those abbreviations. Okay, let's continue on with authentication of patient records. Let's talk about now timeliness and how important that is as it pertains to patient records. Patient record entries should be documented as soon as possible after care is provided, because that helps to increase the accuracy of the information recorded. In other words, the minute that a patient is given a shot, or a patient is given meds, or a patient has a procedure done, they had some vitals taken, whatever is done to that patient and needs to be recorded in that medical record, it should be done as soon as possible. Now, according to Joint Commission, once a patient is discharged from a hospital, according to Joint Commission, that hospital has 30 days to complete that patient's record. Once a patient is discharged from the hospital, according to Joint Commission, that hospital has 30 days to complete that patient's record. Now, there are times when errors or mistakes may be made in a patient's record, and you need to know the proper way in which you need to correct that patient's particular record. We call that amending the patient record. Is where you correct any documentation that's inside of a patient's record. Now, the only person authorized to correct an entry is the person that is the author of the original entry, meaning that if you made the entry from the beginning, if you made the recording in the patient's chart, if you put the statement, if you're the one who recorded the date and the time and what was done, if you were the person that actually done that, you're the same person that has to amend the record if a change needs to be made. So we're going to talk about now how those records are amended. We're going to talk about how those records are amended. So the very first step that you would do if you had to amend a record is draw a single line through the incorrect information, making sure that the original entry remains legible. So what does that mean? That means you can't scribble, you can't white out, you can't erase. You draw one single line. You can't draw 3, 4, 5, 6 lines. You draw one single line. And when you draw that one single line straight across the middle part of that entry, it should be where the original entry is still visible, although that line is marked through there. The next thing you do is date, specify the time, and sign the corrected entry. You date, specify the time, that means you record the time that you're making the change, and then you sign with your initials the corrected entry. The third thing you do is document a reason for the error in a location as close to the original documentation as possible. So you can say things like, examples would be things like entry made in error, or something like entry made in wrong chart. You can say something to that effect. And then once you document, give a documentable reason for the error, now you want to actually give the corrected information. So you would, the last step, you would enter the correct information, and you want to write this as close to the original information as possible. Now, if the length of information to be entered prohibits this, like say for instance, if you are in the electronic record and it only gives you so many characters per line and it prohibits you from doing so many characters, then what you would do is then at that point enter the information. You will go on down to the next line to enter the information in there. So you got to understand and know the proper ways in which to amend patient records, because you never know when you're going to have to amend a patient's record. And if in any event that you will have to amend the patient record, You want to make sure that you follow the proper steps in doing that. So again, if you can't make the corrected information next to the original because it prohibits you from having so many characters, enter the corrected information in the next available space in the record and then reference it back to the original entry. Now, right after the slide that talks about amending patient records, there is a picture of a signature stamp there. It has John Doe on it, just to give you a feel, if you've never seen a signature stamp, just to kind of give you a feel of what one looks like. There's also, after that, there is an example of what an abbreviation list will look like for the facility. And in this case, I have one in here as an example for Sunny Valley Hospital. This is just an example of a particular list of abbreviations that are allowed in their facility. Now let's talk a little bit about the development of the patient record. The development of patient records. Patient records are developed from many different sources. Okay? So, what do I mean by that? Well, inpatient record might actually become created prior to admission, and that's usually because pre-admission testing may have to be done. So anytime a patient has to be admitted to the hospital, but they have to have pre-admission testing, actually at that moment that patient has that pre-admission testing, their patient record is actually developed and created at that moment. So when you are creating patient records, the one thing that you want to always make sure is that you keep the most current document filed first in a section of the record, meaning that you always file with the current date on top. That's the way you want to always file, because you always want to make sure you keep a patient's record current. Okay, then you have the outpatient record. In the outpatient setting, records are more frequently retrieved because of the frequency of patient visits. So what does that mean? Normally, and when we say outpatient, let's look at individuals that may come to the emergency room, may have a lot of outpatient surgeries. Normally, you're going to visit those patient records quite frequently. And with outpatient records, each time an outpatient receives a service such as an x-ray, the record must be retrieved and sent to the outpatient department. Because patients usually receive more frequent outpatient care, these records are retrieved more frequently. So just keep in mind, as managers going into outpatient settings, whether you work in an ambulatory setting, or you want to work in an emergency room department setting, or you want to work in some sort of outpatient surgery center, you're going to have more frequency to patient records versus if it was a hospital record. Because with a hospital record, a lot of times when the patient is discharged, you may not see that patient for a while. But that's different when it comes to outpatient records. Same thing with physician office records. With physician office records, you have what you call continuity of care, which means that the main purpose of the physician office record is to provide documentation to assist in the continuity of care. And so the development of the office record varies. Because again, even in the physician office, you may not have patients that come every month. You may have some patients that come every 6 months, Some patients that only come once a year. You may have some that come 2 or 3 times throughout the year, but it's spaced out. So how much access you have to that patient record pretty much depends on how often they visit the doctor's office. However, in every case, you want to continue to keep the continuity of care. So with a physician office record, you don't look for, you shouldn't see a whole lot of fluctuations with patient records, because a lot of times they're coming for the same thing. Just like, like a patient that may come once a year to get a pap smear. Well, you pretty much know her record is pretty much going to look probably the same as far as what she's coming for, because she's just coming for the yearly exam. Or if you got somebody that is a known diabetic that comes to you every 3 months for their A1C to be drawn, or somebody that's on blood thinner and they're coming once a month for you to check their levels and things of that nature. Now let's talk about some different patient record formats. And I have a list of them here in the slide. So primary and secondary sources of information. Primary and secondary sources of information. Primary sources of patient information, some examples of those will be things such as x-rays, scans, EKGs, and other documents of clinical findings. Secondary sources of patient information will be things such as incident reports, if the patient is on some type of registry, or patient indexes. Okay, and then you have what you call source-oriented record. This is where, and I have in the definition on the slide, maintains the report according to the source of documentation. So what does that mean? That means that all documents generated by a nursing staff will be located in a nursing section. I'm going to say that again. An example of SOR, source-oriented record, would mean all documents generated by the nursing staff are located in the nursing section of the record. Radiology reports would be generated in the radiology section of the record. Physician-generated documents, so things like physician orders, progress notes, all of those will be in the medical section of the patient record. So each source of data in an inpatient record has a labeled section. And if you've noticed in patient records in the hospital, they usually have tabs in those patients' records. Those records are kept at the nursing station, and they usually have tabs. Those tabs are for varying things. There may be tabs in there for dietitian, tabs in there for any x-rays, tab for labs, tab for physical therapy, doctor's progress notes, anything pertaining, the MAR, the medication record, anything that pertains to that patient usually is divided into sections, and all of those records are held in those particular sections of the patient record. Now, just like you have a SOR, a source-oriented record, you also have a POR, a problem-oriented record. Now, in this particular section, this is the section that pretty much has information as it pertains to whatever problems the patient may be having, whatever their plan is, like their initial plan, and updated progress notes. So when we talk about plans that the patient may have, that could be diagnostic or management plans. That could be therapeutic plans, such as goals, procedures, any type of therapies and treatments that are used to treat the patient. And it could also be in reference to patient education plans. Plans to educate the patient about whatever their condition is. So like say for instance if it's diabetes and the patient is a first time being diagnosed with having diabetes, one plan of action would be to take that patient through diabetes education classes so that they can learn about the disease, knowing what to do if the blood sugar goes too high, goes too low, if they get sick, what they should do, when should they call the doctor, things of that nature. So that could be considered as a initial plan in the POR section of the patient record. Now, for progress notes, one way that progress notes are documented in a patient's chart is using the SOAP method, S-O-A-P, SOAP method, S-O-A-P. So let's talk about each one of those real briefly. The SOAP structure stands for this. The S stands for subjective. So in that means the patient's, this is the patient's statements about how he or she feels at the moment. Do I have a headache? Am I nauseated? The O in SOAP stands for objective. Basically, these are observations about the patient. This is where physical findings, lab or x-rays are done. For example, chest x-ray negative. Blood glucose normal. Blood levels normal. A is for assessment. This is the judgment, opinion, or evaluation that is given by the healthcare provider. So a patient comes in complaining of headaches. The provider may assess that the patient had an acute migraine. P is for plan. What things will be used to resolve the patient's problem? Will it be diagnostic, therapeutic, or some type of educational plan? So let's go back to this. Go back to the beginning. Patient appears with a headache. Okay, the doctor does his findings and find that the patient has an acute migraine. So one way that he resolves the problem, he gives the patient permission to take Tylenol for pain as needed. So that's what we mean by SOAP: subjective, objective, assessment, plan. When do we archive records? When are records archived? That solely depends on the location and is based on federal and state laws, because some states have different laws as when records are to be retained. And it pretty much depends on that particular state. However, records should be stored in areas that are set up to keep those records confidential. Okay, even though records are being stored, whether they're on-site, off-site, stored on a CD, no matter how they're stored, at all times, HIPAA regulations should be followed at all times for the record. Doesn't matter how it's stored. There are, however, some different ways in which to store records, and I have them listed in the slide for you. One way is off-site storage. One way is off-site storage. And usually these are contracted facilities that hospitals and other medical facilities use for storing patient records. Now, does this mean that patients don't have to sign if they want their medical records? That does not mean that. Patients still have to sign a release form if he or she wants access to their patient record. The off-site storage is just a place for the facility to store their records because they don't have a place inside the facility to store the records. It's just easy for them to do an off-site storage. You can actually archive records on what you call microfilm. So basically with microfilm, it records the original paper record on a film, and then Once it records it on the film, it's then ready for storage. You can also do optical imaging. This is basically where you convert a paper-based record to a optical disc. It's just for faster retrieval. And it is much faster to retrieve something electronically versus if you have to depend on retrieving it by paper. Records are retained. Records are retained for a significant period of time. Again, that solely depends on the federal and state laws for that particular state. Every state usually have varying limitations as to when or as to how long records are retained. And lastly, we're going to talk about what is the patient's responsibility, patient record completion responsibility. So, who's responsible for completing patient records? That's basically that's the last thing we're going to talk about in chapter 4. Who's responsible for completing patient records? So, the governing body and the facility administration. What is their responsibility when it comes to record completion? They're responsible for ensuring that each patient receives high quality medical care, and they're responsible for making sure that care that is received has been documented completely and accurately in the patient record. The facility administration is responsible for ensuring that medical staff follows rules and regulations that provide for the maintenance of completing patient records in a timely fashion. And the facility administration is also responsible for enforcing policies. So whatever your policy is, whether you're in a doctor's office or you're in a hospital, whatever your policy is for maintaining patient records, you're responsible for enforcing those rules and regulations. HIPAA is a big thing now, and it's not to be taken lightly. And you cannot just take a patient record and just treat it any kind of way that you want to. You have to hold some responsibility for it, and you have to hold your employees accountable as well. Also, attending physicians and other healthcare professionals. The attending physician is the person that's ultimately responsible for documentation in the patient record. The attending physician, he's ultimately responsible for it. So a doctor holds a great responsibility when it comes to patient records. He holds a great responsibility. He's bound by laws and regulations because he has to be sure that those things that are documented in a patient record is complete and accurate. So now this concludes the notes or the lecture for chapter 4. So we're going to move right on into chapter 5. So now chapter 5 just kind of picks up. And whereas in chapter 4 we talked about the patient record, we went inside and just talked about what is a patient medical record. Chapter 5 goes in and talks about electronic health records. So chapter 4 dealt more with patient records in a paper format, basically, whereas chapter 5 talks about patient records in an electronic format. So, when we talk about the electronic health record, you may hear a lot of people call it EHR or EMR. You may hear it referred to as those particular names. A lot of times you may hear it called computer-based patient record. So, whether you hear EMR or EHR, the one thing that you want to, the difference pretty much in the two would be this. When you hear EMR, basically that refers to document patient care by way of a computer. And with that computer, you're using a keyboard, a mouse, you may be using a voice recognition system, you could be using a scanner or some type of touch screen. In electronic health record, basically that just refers to the collection of the information that's documented by providers. Okay, so you may hear it called EMR, EHR. So what's a longitudinal patient record? Anytime patients go from one facility to another, their records are linked, meaning that their patient record follows them everywhere they go. We call that a longitudinal patient record. So say for instance a patient starts in the emergency room, patient record is first generated there. So they're admitted to the hospital 2-3 days, the patient record follows them from the emergency room to the hospital. Then they have to have a follow-up with their primary physician. Now the record follows them from the ER, from the hospital to the primary care physician. And if they have to go on and see a specialist, the record follows there. So their record just continues to follow them wherever they go. And we call that a longitudinal patient record. So we haven't always been electronic with patient records. Haven't always. There are advantages and disadvantages of having paper records. So what are some advantages of manual records? I have them listed in the slides for you. When you have manual records, you have very low startup costs. You don't have to worry, and that's because you're not buying any kind of machinery. You're basically just buying supplies at that point. Training staff is much easier when you have manual records. It's so much easier. You don't have to have as much you don't have to have as much trained staff when you're dealing with paper records. And then one thing about paper records, they'll always be available anytime your computer system is down. There are, however, some disadvantages. A lot of times with paper records, it's not always easy to retrieve those records, especially if the facility does not have a filing system or a good filing system. I put it like that because a lot of them have a filing system. It's just not a good system. So a lot of times you don't have a good filing system, retrieving paper records is hard. In manual records, everything's handwritten. So that can be difficult because not everybody writes neatly. And it's hard, and it is hard. A lot of times it's hard to read a physician's handwritten information. It's difficult to abstract information when you have a manual record because if it's electronically, it's much easier to transcribe, but it's more difficult to transcribe when it's in manual format. And another disadvantage is services that weren't documented. They're not easily traced through a paper through a paper chart. They're more easily accessible through something electronically. Because a lot of times electronic systems are set up where if you don't put information in a certain field, it'll usually block you, won't let you go any further. It usually tell you something is required in that field before you move on. Well, when you have manual paper records, you can't always get that undocumented service, and usually it's not even caught until after the patient has been discharged. So now, what are some advantages of having automated records? One advantage is much faster access to patient information, much faster access. Everything's readable. It's easier to read the information. It eliminates a whole lot of paper storage, and you're actually able to capture data on a patient in a much more timely fashion. Whereas some disadvantages can occur. One other advantage, before I talk about that, one other advantage of automated records is that you can have a reduction in administrative costs, because it gets costly with buying supplies and things of that nature. But with automation, you don't have to buy as many supplies. Now, the disadvantage, though, even though I'm not buying the supplies, the startup cost is more expensive, because you've got to invest in computers, you got to invest in the software, you have to invest in the maintenance of that, and then there's so much other things you have to worry about as far as the amount of training that you're going to have to give to staff, and that can get costly, because you can train a person for like 2-3 weeks, and then the person end up leaving, getting terminated or something like that, and then that's time and money that you've wasted. A lot of times with automated records, one disadvantage is user resistance, and that usually comes about when you have individuals that don't like computers, or individuals that are at a disadvantage when using computers. They're not computer savvy. That can be a disadvantage for you when you're dealing with automated records. So let's talk about the transition to electronic records. One of the transitions that has been made to electronic records is what we call scanning of documents. What needs to happen before you scan a document? There are some things that should take place. Most individuals have documents that come to them stapled. Most of them have documents that come to them with paper clips or some other kind of fastener. Anytime you get ready to scan documents into a system for retrieval, for storage, or transcribing, you always have to remember to move all staples, paper clips, and fasteners from the documents. Okay, because if you do not, that's going to be picked up. A lot of times that's picked up in the scanner, and then sometimes it jams the machine because of the devices that's used on that paper. So you have to remove all of those things first, and then you have to make sure that the patient's name and the medical record number appears on each page. Why is that so important? Why have the patient name and medical record on each page? That is in the event something gets misplaced. Let's say, for instance, you got 2 or 3 patients' records, and for whatever reason, the papers and stuff got mixed up. You're much able to put those papers back together based on whose record it is, because you have the patient name and the MR number on each page. If there's any pages that have tears in them, you want to always repair those before scanning them in, because, again, the scanning machine is going to pick up all of those different things. What is a hybrid record? A hybrid record is where you have a patient record that part of it is manual and part of it is electronic. So, who is the Regional Health Information Organization? Basically, this is a network of individuals from different regions. Their job is to oversee electronic records. Individuals that are involved in that would be hospitals, physicians, patients, public and governmental health agencies. They're all a part of what we call the RHIO. Okay, now we're going to talk about, for a few minutes, I want us to talk about some varying components of electronic health records. And this is just some general terminology that I want you to know. So when we talk about character spheres records, now keep in mind, we're talking about electronic health records. So these are things that's done at a computer. So when you're at a computer and you're getting ready to input information, and the instructions that you're inputting says something about make sure that your characters are in proper format. When it mentions the word characters, it's talking about things like lower and uppercase letters, numerical numbers, or special characters. Special characters be things like the @ sign, the pound sign, the dollar sign, the percentage sign, the asterisk, parentheses, exclamation points, plus, equals, minus, slashes, dashes, semicolons. All of those are classified as special characters. Anytime there's the word fields, fields are the group of characters. And then records are the collection of the related fields. So you start out with characters, characters turn into fields, fields turn into records. Records then turn into files. Files then turn into data. Data is the raw facts that are not interpreted or processed. These are things, numbers, letters, images, sounds, symbols, and sounds. And then data then turns into information. So you have characters. You start out with characters. Characters turn into fields. Fields turn into records. Okay. Records then turn into files. Your files now turn into data. And data is what gives us the information, because now that data has meaning and it helps physicians and healthcare professionals to make some sort of decision on that patient's health record. I put in the slides a picture of a patient registration screen so that you can kind of see a little bit of what one looks like. Just kind of get a general idea. You should remember this from medical administrative practices. So now there are two different applications associated with electronic record medical records. You have an administrative side and a clinical side. Two different applications associated with medical records. You have an administrative side and a clinical side. So, what is the difference between the two? Administrative applications. This applies to administrative. This applies to patient registration, patient scheduling, patient admission, business functions, financial functions, and other management applications. When we talk about the clinical applications, I have those listed for you. This is anything that involves monitoring the patient system. So that could be pharmacy, lab, radiology, nursing, or any other medical documentation. So basically, clinical applications include the collection, storage, and display of all clinical information. So every time you open a patient's medical record, you're going to always have two sides. You're going to have an administrative and a clinical side. The administrative side is everything that's done to the patient record prior to anything clinical based. So again, registration, scheduling, business transactions, financial transactions, and things of that nature. And then the clinical aspect is those things that are done to diagnose and treat the patient. So I put a slide up here of an example of a patient registration demographic information screen. I put you a slide in here that is an example of patient history on the clinical side. I put you a slide in here of an example of a patient intake screen. So an intake screen is usually that screen that has things like patient's vital signs, height, weight, what blood pressure was, their temperature, and then just like the general appearance of the patient. Was the patient lethargic? Was the patient hot? Was the patient red? Was the patient itching? Or, what was their skin like? Did they look dehydrated? That's what a patient intake screen looks like at the time of examination. So the transition to electronic records, and this is our last slide, the transition to electronic records, a whole lot of challenges have come with that. Just about everything that you do now is electronic. Every part of the medical field, whether you're in a physician office, hospital, everything has transitioned to electronic records. There's a lot of challenges that have been met for that. For some individual, it's still going to take some time for them to transition all the way out, because you still have some physicians that are old school. They still like to use paper charts. So it's going to take them a minute to kind of get all the way acclimated to using electronic health records, but it's coming. It's a slow process for many. It has been a fast process for lots. So now this concludes the lecture notes for chapters 4 and 5. Again, this is just an overview or a briefing of the notes. Students are still expected to read the chapters for chapter 4 and 5. Make sure you especially read through the terms and definitions that are always located at the beginning of each chapter. Again, this audio lecture will be uploaded into the student portal in the classroom, and you also will have availability to the PowerPoint notes separately for both chapter 4 and 5 located in Doc Sharing. Thank you.